Um, so this webinar series tonight is the first of a four-part series of webinars that we're going to be doing. They are following an in-person and for some people virtual event that we did this spring called the Health Empowerment Revolution. We held that in Phoenix, and it was talking about migraine and other coexisting conditions that many people, especially women, are living with. And coming out of that series, we wanted to do these webinars that would be a little bit more interactive and give folks time to ask questions and get their specific questions answered. To introduce myself, I am Katie McDonald. I am the incoming executive director for Miles for Migraine. I've been with the organization for about 10 years. I'm going to introduce our two panelists in just a moment. But I think about half the people that are joining tonight are new to Miles for Migraine, have never attended an event. So just to give you a little bit of background about who we are, we're a national nonprofit organization that exists to help improve the lives of people living with migraine and headache disorders. And we put on events like this, educational opportunities to help people better understand the disease and the treatment options and advocacy. We also offer support groups 6 days out of the week. Those are virtual, they're free. I highly encourage you to check those out, especially if you are feeling alone in your journey with migraine. We have walk, run, relax events in 21 cities around the country. And we also offer an advocacy training program that is run together with both fellows or doctors getting into the field, a specialty field of headache medicine, and for patients. They work together through that. It's a 9-month program. So that's a little bit about Miles for Migraine. I want to thank our sponsors tonight who helped make this event possible. That is Haleon, Pfizer, and AbbVie. And then before I introduce our panelists, another thing I wanted to share, many of you, when you registered for the event, you submitted questions that you had specifically about menstrual migraine. And so we reviewed those questions and we've incorporated a lot of the themes and of the questions that we saw into the presentation tonight. So we hope that we are able to answer a lot of the questions that you have. As additional questions come up, feel free to put them into the Q&A and we will address those in the second half tonight. We're going to take about 30 minutes to go through the presentation and about 30 minutes for the Q&A session afterwards. All right, so to introduce our panelists, we have Dr. Jelena Pavlovich. She is an associate professor of neurology at Albert Einstein College of Medicine and chief of neurology at the Einstein Hospital of the Montefiore Medical Center. She also directs research and clinical trials at the Montefiore Headache Center. In addition to being a practicing neurologist, she holds a PhD in molecular biology. Her research interests broadly focus on hormonal regulation of migraine in women, and specifically, she aims to answer the question how hormonal fluctuations affect migraine symptoms during the menstrual cycle and across the transition to menopause. Dr. Pavlovich has published extensively on migraine in women. In recognition of her outstanding achievements, she's been awarded the Harold Wolf John Graham Award in Headache Facial Pain Research by the American Academy of Neurology and is the recipient of the Women's Health Science Award from the American Headache Society. Thank you so much for being here with us today.
It's my pleasure. Thank you for having me.
Of course. And then we also have Dr. Jessica Ailani, who is the director of the MedStar Georgetown Headache Center and professor of clinical neurology at MedStar Georgetown University Hospital in DC. Dr. Ailani completed her neurology training at NYU in New York and a headache fellowship at the Jefferson Headache Center in Philadelphia. Her research interests include migraine treatment and women's health, and migraine including pregnancy and menses. She's a principal investigator in several clinical trials focused on migraine treatment and enjoys being involved in protocol creation and data evaluation. Dr. Ailani is an active member of several associations. She's on the executive board of the American Headache Society and for the American Academy of Neurology. She is vice chair of the Division Chiefs Committee. All right, and with that, we're going to pull up the slides and get started.
Well, okay, I'm going to go ahead and share the slides. It is a pleasure to be here. Thank you, Katie, for that introduction and for inviting us. And it is also always an honor and a pleasure to do this with my good friend and colleague, Dr. Ailani. Thank you all for submitting your questions. As Katie has already mentioned, we reviewed them and structured our introductory lecture part based on those questions and trying to address as many as possible. So as you know, we're speaking about menstrual migraine and how to understand the cycle and as hormones affect women both on two time scales, the monthly time scale, which is around the period resulting in menstrual migraine, and a lifetime scale, which involves from teenage years to the menopausal transition, and how this all affects life and how can we improve the lives of those of women who have migraine. So you asked and we tried to answer briefly, of course, and this is meant to not be medical advice, but an informative session. These are the categories of questions that you asked us most, and that also in our experience, our patients ask most of us. So we will go through definition and mechanism. Dr. Ailani will review diagnosis and tracking. We will go over the treatment options, which is obviously the question everyone wants to know most often and was most frequently asked right now as well. Hormonal interventions from birth control and hormone therapy. Briefly over perimenopause and menopause and why many experience worsening during this time. Finally, some lifestyle and non-drug options and addressing teens and special populations. There's a lot to cover. We will go over this broadly. First, focusing on definition and mechanism. So how do we, as everything that we have in medicine, we have to define. So how do we define it? And therefore, how do we come to understand what actually triggers migraine around menstruation? So there's two major diagnoses that exist in this concept that we headache specialists use called the International Classification of Headache Disorders. And these two disorders are considered as pure menstrual migraine. They're named pure menstrual migraine and menstrually related migraine. And the concepts are easy to understand. Fundamentally, they focus on the perimenstrual window where the first day of bleeding is the day number 1. And when you back out from that, so 2 days prior to the onset of bleeding, prior to the first day of menses, and then through the first 3 days of bleeding, creating a 5-day window. And so somebody who has pure menstrual migraine would have experienced attacks only during that 5-day window and not at any other time. So just during that interval. This is a very rare condition, understandably so. And the much more frequent condition, the much more frequent version of this, of how perimenstrual migraines presents, is that women experience attacks during that same window, -2 to +3. So it's 5 days, right? With +1 being the first day of bleeding. And then they also experience it at other times, which if I was a betting person, I would bet that that is the experience familiar to most of you. And this is called menstrually related migraine. The attacks themselves are often called menstrual migraine, menstrually related attacks. And then the disorder, the diagnosis is also called menstrually related migraine. And we understand that this can create confusion. What is the attack? What is the diagnosis? And it's a distinction that we worry about a lot. But that for your purposes as a patient, really the concept or when am I really suffering is a much more important one, I would say. So why does this happen biologically, right? Everyone wants to know why, how, why me? Well, as women, we have biological women have hormonal fluctuations that are characteristic to those who have X chromosomes, right? And this means that estrogen and progesterone and other hormones, but particularly estrogen and progesterone, circulate during the menstrual cycle, during the time, however long the interval may be, in a kind of an orchestrated way. And prior to the onset of menstruation, estrogen falls somewhat rapidly together with progesterone. It is the fall in progesterone that causes bleeding, but it is the fall in estrogen that causes most of the other symptoms. Specifically in migraine, the drop in estrogen destabilizes pain pathways, and this affects neurotransmitters like serotonin and also signaling peptides, CGRP here, which stands for, I will say it once and then we'll go with CGRP, calcitonin gene related peptide. It is a neuropeptide that's really specifically, it exists throughout the body, but it's very specific to the structures in the brain and brainstem that are really involved in migraine activation and migraine propagation. And so targeting this inflammatory peptide, neuropeptide, is very important, and as we know, affects migraine really well. And targeting it means, and down regulating it means that one gets to control migraine. But in terms of the mechanism, these falls in estrogen are normal. This is the normal cycling of hormones that just results in symptoms. And in those who have genetics of migraine and therefore have migraine, just results in accentuated symptoms related to migraine. There are also prostaglandins. When estrogen, when the hormones drop, there's also release of prostaglandins, which are inflammatory molecules that are released non-specifically. And this happens during menstruation, which leads to a lot of kind of menstrual pains and aches that are familiar to everyone who has menstruated, and but also happen in migraine. And this is part of the reason why non-steroidal anti-inflammatories, drugs such as ibuprofen and naproxen, help, because they downregulate these inflammatory molecules. Now, is it just estrogen? This is a common question. Is it only estrogen? It is almost always estrogen. It is not only estrogen. Hormones don't operate in isolation. Estrogen interplays with other hormones, but it is predominantly estrogen. So without getting into the nitty-gritty of science on this, yes, it is mostly estrogen. And what about progesterone? Many studies have looked at progesterone and changes in progesterone and have not found progesterone to be the culprit of menstrual migraine. Again, it is estrogen. And what about other hormones? We have looked at other hormones, and again, they don't seem to be the culprit. For sure, they're playmates of estrogen, and they go up and down, and all of this is in very, very specific orchestration of hormonal changes. But again, it is estrogen. And I will hand it off to Dr. Ailani for diagnosis and tracking.
All right. So as Jelena said, making the diagnosis is important for many reasons. Menstrual migraine can be a little bit different than a routine migraine attack. And so understanding these differences and why one might have different symptoms because of menstrual migraine, it's important then that you get that diagnosis, and treatment might vary as well. All right, I don't think I can forward these, so I'm going to make you do the hard work here of pushing the next one.
So there you go.
All right, let's go to the next slide, and let's talk a little bit about what's the difference between menstrual migraine and all the other migraines the rest of the month. Going back to this idea that when we're talking about menstrual migraine, there are these two types, the pure menstrual migraine and menstrual-related migraine. Pure menstrual migraine really, I think, is something that occurs when a woman is very young and first starts to get her cycles, and she might notice, I'm only getting a migraine attack right around my period, and then I'm fine the rest of the month. And then as they grow and they get older, they still have those attacks around their period, but then they have attacks other times of the month as well. And when you really start to separate it, they can tell you that those attacks that come with their cycle, there's something different about those. They're a little bit stronger. Their usual medications don't work. They come with more nausea. They often don't have aura related to them, where maybe some of the other attacks might. And they come and go over several days. It's rare that a person will just have one day of a menstrual migraine attack. It usually will go away with treatment, then come back the next day, and then go away with treatment, then come back again. And this, I think, is extremely frustrating for our patients. It's frustrating for us too as the clinicians, because we're trying to come up with a plan to treat the attack, but these multi-day attacks can be hard to treat. One thing that women often will ask or wonder about is, what if it's happening mid-cycle? Is that a menstrual migraine? No. The menstrual migraine, as we talked about, really is within those first 2 days before bleeding up until a couple of days into bleeding. If it's happening other times of the cycle, it could just be a routine migraine. It could have to do with other fluctuations in hormone, but it's not considered menstrual migraine and should be treated a little differently. So the best way to make that menstrual migraine diagnosis is keeping a calendar. And I'm sure as patients, you've heard about calendaring. I try not to push my patients to calendar all the time for the rest of their life because it's really frustrating. But if you're trying to figure out if you have migraine with menses, then keeping a calendar where you track your menstrual cycle and you track your migraine attacks is going to be really important. And what you're seeing here is a woman who's tracked her migraine attacks and then also has tracked her menstrual cycle. And you can see that with her first cycle in the month, she has migraine the first 2 days of bleeding. And then later in the month, when the cycle returns, she actually gets her migraine attack starting 2 days before bleeding. So she has two migraine attack cycles correlating with her menstrual attack. So this is something we call menstrual migraine and a confirmed diagnosis. You need to have at least 2 out of 3 cycles with the association of migraine and menses. So super helpful. We can look at this calendar and say, oh, you in fact do have menstrual migraine. But I'll say most of our patients have already figured that out on their own, but this just helps to make that diagnosis. So next slide.
So the most frequently asked questions of what are the treatment options? Dr. Ailani already mentioned that these tend to be the most frustrating, most debilitating attacks, right? So what is most effective for them, and should they be treated differently? Many of our patients come with the experience where their over-the-counter medications work. They've done well. They didn't need us for N number of years of their lives. They managed fine with over-the-counter medication. At some point, their perimenstrual attacks, they're noticing when the attacks occur around their menstruation, they're just not going away. They're just worse. And these over-the-counter medications are not working. And this is time when often women will seek help and when we will see them. And so they're frustrated with it, and they finally realize they may need prescription treatments and may even need to consider prevention. So what are the most common acute treatments? Again, NSAIDs, for those who can take NSAIDs and those who are responsive to NSAIDs, such as ibuprofen, naproxen, and there's a whole group of other NSAIDs, but ibuprofen and naproxen being over the counter, though the higher doses are through prescription, and we often do that. And there are other options like diclofenac and albumetone and celecoxib and so on that we can also prescribe. These often counter the prostaglandin that is driving these attacks and also can mediate other aspects of pain and can work well for many. Just in often requiring higher doses than the doses used on your non-perimenstrual days. Triptans are the mainstay of acute migraine treatment, and for that, many of them work in perimenstrual attacks, particularly longer acting ones, frovatriptan and naratriptan. And the advice is to really treat early and treat the full dose. The advice is always to treat early, but sometimes we can get away with not treating early those, everyday attacks, so to speak, or non-perimenstrual. But when it comes to perimenstrual attacks, which tend to be the most severe, most burdensome, associated with most other symptoms, this is where it really matters that longer acting and really full dose triptans are being used. So frovatriptan and naratriptan as the longest acting triptans are the ones of choice. And they can be used for a longer period of time that we will review. And then combination is sometimes often needed, and that is that doubling up the triptan and an NSAID often will provide support where one or the other falls short. Now, the newer medications and various tailored approaches, we do know that now that we've had the CGRP revolution, and particularly with acute treatment using CGRP methodology, gepants, which are small molecules that act at the receptor of the CGRP, and in that way prevent acute attacks or treat acute attacks. They can also be used for prevention, but these drugs, rimegepant and ribagepant, in this context are used for treatment of the acute attacks. And these are very valuable, particularly in patients who are either can't take triptans, are triptan non-responsive, and particularly those who have cardiovascular contraindications or other types of contraindications, either to NSAIDs or to triptans. That said, perimenstrual attacks often may require three-pronged or multi-pronged approaches with combining several agents. And in the end, sometimes when the acute treatment with several agents is not sufficient, they may require prevention. And for many women, prevention does not need to be a full month of prevention, which is the traditional prevention that most of you who have been introduced to the idea of prevention have heard about. For most women, a concept of mini prevention is sufficient if they mostly have perimenstrual attacks. And this is practiced in a way where about a day or two prior to the expected attack, after careful review of the diary that Dr. Ailani just reviewed with us, you and your physician would review the diary, realize that if migraine really reliably starts, let's say on the day -1, 1 day prior to the onset of bleeding, that then a day prior, on day -2, you should likely start taking either NSAIDs or a long-acting triptan, frovatriptan or naratriptan, or maybe magnesium if you're averse to NSAIDs or triptans, or even a gepant twice daily for about 5 to 7 days max. And this works best in those who have a predictable cycle, who track their cycles, and can really utilize this approach very effectively and get great results with it.
I do want to say one thing about predictable cycles. Some women, many of our patients are on birth control and are still taking those blank pills in your birth control. That makes your cycle super predictable, as long as you're not towards middle or end of perimenopause, where kind of the whole game it's a different story. But if you're still taking those blank pills, and that's when you most likely are going to get that menstrual migraine attack if you have them. And so you can either decide to skip those blank pills after talking to your clinician about it, or you can do that mini prevention at that time. And I think that's an important thing to realize. So we're going to talk a little bit about hormones and how hormones can be potentially helpful for women who have menstrual migraine, and both hormones as in birth control, or if you're on hormonal treatment as you're getting into perimenopause. Now, can this help menstrual migraine attacks? Can it potentially stop menstrual migraine attacks? Does it matter what kind of hormone you're taking? Well, the answer is yes, yes, and probably yes. So let's talk a little bit more about the types of hormones that are available. Now, if you don't have a history of migraine with aura, then you may consider taking a hormone treatment that contains estrogen. And you want to have kind of an even level estrogen through the month, and you want to skip your cycle. So really the best way to do it is a continuous stable dose hormone through the month. We're not having those dips and peaks in your estrogen levels, which then also provokes dips and peaks in other hormone levels and might be the cause or the trigger for those menstrual migraine attacks. If you have a history of migraine with aura and have had that conversation with your clinician that maybe estrogen-containing compounds aren't a good idea for you, you can then consider progesterone-based treatments. And so they are things like IUDs or progesterone-based birth controls to think about. While this might not really stabilize that estrogen fluctuation too much, it can still provide a sense of control. And we have many patients on IUDs who don't really cycle so much anymore. They might notice a day or two where they have soreness in their breasts, they're a little moody, they crave certain foods, and then maybe they get a migraine attack, but it tends not to be as severe or as significant as it was in the past. And for many women, especially those who just don't bleed anymore, they feel like all of the symptoms are much easier to control with their acute migraine treatment. And they don't necessarily have to have like a mini prevention that they're doing a certain time of month. If you're in that perimenopausal time period or you're in menopause and you're noticing worsening attacks, especially you think hormonally related, and you've had that conversation with your clinician, you might want to consider going on estrogen treatment with a transdermal patch. Again, it provides a very steady, stable dose, a pretty low dose of estrogen. And this is something you can talk to your clinician about, even if you've had aura, because the study suggests that transdermal dosing of estrogen is very low and probably does not provide as much of a risk. So that's going to take us right into perimenopause and menopause.
Exactly. So, what to do in perimenopause and menopause, right? Why do headaches frequently worsen in perimenopause, and what can we do to help? So, I already mentioned that it is the estrogen fluctuation in estrogens, and particularly the drop in estrogen, that causes perimenstrual attacks. And during reproductive years and during ovulation, that drop in estrogen is orchestrated and predictable most in majority of women, and especially in those on birth control, as Dr. Ailani just mentioned, it is highly predictable. What happens in perimenopause is that erratic changes and just fluctuations in hormones start. Progesterone starts to blunt down and kind of just steady decrease with a little bit of oscillations. But estrogen likes to kind of dance and go up and down on top of that steady decreasing progesterone. And those swings in estrogen are really the cause of majority of symptoms that are associated with perimenopause. We know this for a variety of symptoms, primarily vasomotor symptoms such as night sweats and hot flashes that many women experience, but for other symptoms as well. Women who don't have migraine will also experience frequently worsening of just headache, not migraine, but headache during this time. But those who have migraine will see increase often as estrogens, particularly those who had perimenstrual and menstrual attacks while they were menstruating now, which means that they're highly susceptible to fluctuations of estrogen. They will see a worsening of their headache and a real upstick in migraine during menopausal transition and perimenopause. As the hormones quiet down and become less of fluctuation of estrogen happens as the menopausal transition comes to an end, approaching menopause, which is kind of the final of it, the year after the final menstrual period. Finally, the headache frequency should subside, and migraine on its own should improve and ameliorate in majority of women.
So let's talk about some things you can do through this entire time period that are not related to taking medication. All right, next slide. For anyone with migraine, we often talk a lot about lifestyle changes. And so there is the idea of regular sleep and wake times, which I find to be sometimes very difficult, but important to really keep regular in your life. Regular hydration, regular meal times, regular exercise. These are all really important things. There are some supplements that we can add in that might be helpful as well. For my patients who have menstrual migraine, I like to ensure that they're taking a magnesium supplementation and then just watching to see if it helps to reduce the frequency of migraine attacks overall. There are other vitamin supplementations such as B2 and CoQ10 that have some good evidence in helping to reduce migraine frequency. I always think it's important you try these one at a time, or you're going to end up on all three forever if you get better, because it'll be hard to say if one in particular is working for you over another, unless you're buying one of these combination migraine supplements that is meant and built to be used as a combo supplement, then you can see if that works for you. So I talked a little bit about this regularity in sleep and exercise and lifestyle, but I do want to mention it's really important that you don't fixate on eating a special diet where you're removing several things from your diet. This really doesn't have great evidence. And as more time has gone on, we've come to realize that blaming your diet is just blaming yourself for a genetic disorder of the brain that you've inherited. And so it's better that you just ensure you're eating healthy and you eat small, frequent meals. You get lots of protein, which is a great fuel for your brain and also just good for your heart and your overall health. but you don't try to fixate on what am I doing wrong that's causing these to occur. It's just, the way we're built, and this is what's happening. And it's better to try to regulate things around that as much as you can. If you're having trouble with the regularity, you're getting a lot of stress, you're handling a lot of stress at work, because come on, perimenopausal time period especially is a intense time for women. Your kids are getting older, you're starting to get elevated at work, and you're just juggling a lot of things. This is where trying to manage your stress with meditation, guided relaxation, cognitive behavioral therapy, biofeedback, these kinds of things can be extremely helpful in really keeping that lifestyle regular and your stress diminished. All right.
I love what you just said, and so true. And I do want to double down on don't blame yourself for the genetic disorder that is highly complex. And the question, the burden of the migraine patient to wanting to find the answers. One is the want, but the expectation that it's up to the patient to fix it, and to fix it by a stringent diet, and only if I was perfect this would be fixed. Unfortunately, that is not the case, and none of us are perfect. And please eat regular meals and healthy diets, as Dr. Ailani said, and don't punish yourself with diets that really don't have evidence that they help, even if they are helpful in a short run. They're just not sustainable most of the time for majority of patients. So let's just quickly go over some points for teens, and how to focus in that life stage. So oftentimes, and I wouldn't be surprised that this is the case for many of you, my first migraine occurs with the onset of the first period, so which is called menarche. And so frequently migraines coincide. So as if getting the first period wasn't stressful enough and enough of a life event, those who have genetics of migraine often will have also their first migraine together with that event or close in proximity to it. This can be extremely stressful to the teen, to family of the teen, to mothers and grandmothers and aunts who may have migraine themselves and who will find this particularly stressful. It can sometimes also be helpful to have that family knowledge of it that can empower the teen to recognize what it is and be guided kind of by just deep family understanding of the condition. But we always start with lifestyle adjustments for sleeping, consistent sleep, consistent meals, consistent hydration. And of course, minimizing the screen time and stress. These are particularly important. If they're important for all of us, but they're particularly important for teenagers and developing minds. In teenagers, the acute treatments are typically recommended. We start with NSAIDs, which are approved and fine, and then triptans, and the important thing is to treat early, which is something that is hard for teenagers to do and recognize and to implement in the setting of the school. So typically NSAIDs, if in high enough dose, will work sufficiently well, but may have to up it up to triptans. And finally, hormonal therapy is an option, but that once the other options are exhausted, and there really has to be a concern for whether the teen has aura, and to use estrogen with caution, at least in the beginning. Those are just some things to consider. So in summary, what are the things to take away? And we can discuss some of this during the questions and answers. Who should I see? Many of you have asked, who should I see to discuss my menstrual migraine attacks? Gynecology versus PCP versus neurology. If your gynecologist and your PCP are interested in this and feel comfortable with it, they can absolutely treat them. There aren't enough neurologists and definitely not enough headache specialists to help, 1 in 4 to 5 women that have migraine and to see each one. So we certainly have to depend on our colleagues in gynecology and primary care. And oftentimes they can provide wonderful treatment to many of you. And then, so what do you say to clinicians when discussing attacks, right? It is important, as we outlined, to keep the diary, to really focus, zoom into those days of risk and when, because the power of that is the prediction and understanding when you are most likely to have your worst days, because then you can either treat very early when you recognize that an attack is happening during that time, or you can use mini prevention to really boost up the care during those days. Also, lifestyle habits, not, leave some room in those anticipated stressful days and not maybe load every 3 minutes of those days. Focus on, does it happen every month? Does it happen 2 out of every 3 months? Does it happen less often, but it's debilitating when it happens? And stratify care according to that. And then, do the usual migraine treatments work, or does it require something extra special, like we discussed? And do you need a prescription treatment? Do you need to amp the care and seek actually help of neurology for these attacks? And then finally, are there any additional symptoms that occur around this? Is there additional nausea, vomiting? Should there be other treatments, such as for nausea and vomiting, that are included in this whole armamentarium that you would be using around your menstrual migraine? And 3 things that we would, like to kind of just hone home is that, we talked about why does this happen? This is mostly due to estrogen. Estrogen and fluctuations in estrogen are normal fluctuations of naturally cycling estrogen and the drop in estrogen that occurs prior to the onset of bleeding during menses. And these attacks that result as due to the drop of estrogen tend to be more disabling, longer lasting, less responsive to treatment. This is not your imagination. These are fully recognized as very burdensome and very challenging migraine attacks, typically worse than the regular migraine attacks. The treatment, an effective early treatment with full doses of medications such as NSAID, triptans, or the CGRP treatments, and plus the well-timed cycle mini prevention, as well as hormones, can work really exceptionally well for those who can track and follow and implement them. And please track your cycle and attacks, because there's power in that knowledge, and it will serve you well to understand it and to then really focus the treatment at that time. Thank you for your attention.
So Katie, I don't know if you wanted to moderate the questions coming in. I do want to just pre-state, we are physicians, but we can't answer specific questions that you might have about your own care. Those are going to be best handled by seeking an expert that's regional to you. We'll try to answer things in the most broad way possible. I think that, there is a lot that we can talk about broadly that might be helpful for you to learn about. Katie, go ahead.
Yes, sounds great. Thank you both so much. This was just an excellent presentation. I feel like I just got to see a menopause specialist and a headache specialist and all the things at once, which is unusual to have happen. So thank you. A lot of great information. And yes, I agree. We can't answer specific medical questions, but kind of looking at some of these questions at a more broad base. There's a question here about noticing improvements with taking Claritin for seasonal allergies, and have we seen any correlation between antihistamines and migraine frequency and severity?
So, when you look at the pathophys, like what is happening when people are having a migraine attack, the reason Jelena mentioned it is a super complex disorder, and I had said it's genetic. There are 19 different genes that can be affected in many different ways to cause migraine. So no 2 people really generally don't have the same exact expression of the disease. And so for some, histamine does play a role in their migraine attacks. And we see these in people who have other histamine disorders, like allergies and asthma and eczema, which very much travel alongside migraine, those with mast cell disorders, and those that have autoimmune issues where histamine might play a role. And in those cases, it's very possible that suppression of histamine might be helpful, but we have to be careful. Sometimes if we suppress histamine with certain over-the-counter medications like brand name Benadryl, for example, in the very long term, that's actually not so great for our brain functioning. So again, it has to be thought about and balanced carefully. Some of our migraine-specific treatments, like the anti-CGRP treatment category, potentially are reducing that histamine release, and that might be part of their mechanism of action. Some of the newer treatments that are being studied are looking at that as well. Can we decrease histamine activation, and is that going to play a role in treatment of migraine? So I'm not surprised that allergy season tends to be a big time. We see peaks in migraine. We think that probably plays a role with that histamine effect for some, but it's not a universal Band-Aid for everybody.
Thank you. What about neuromodulation devices? Is there anything to suggest that those can be helpful for menstrual migraine? And if so, are certain ones better than others?
Yeah, so there's been a few devices looked at for menstrual migraine. That doesn't mean only those work. Those are just the ones that studied. There's the Nerivio device, the remote electrical neuromodulation. I love to call it the Band-Aid device because it sits right on the arm like a giant Band-Aid. It was actually looked at for menstrual migraine attacks, showing efficacy. And I believe the non-invasive vagal nerve stimulator that sits right on the vagal nerve can be used as needed, has also shown some efficacy. Again, I think that doesn't mean those are the only two that work, but those are the two that actually had studies done showing positive benefit.
Yeah, those are the two where they looked at it. But most patients who respond to a particular neurostimulation device seem to have some benefit during all of their attacks, at least in clinical practice. Those studies have not been conducted for all of them. My clinical approach there is to say, if it works for you, do it. You know your body best. If you notice benefits, continue doing it, especially something like neurostimulation where there's no downside to using it, right? There's no drug-drug interaction. If you're tolerating the particular neurostimulation device well and you enjoy doing it and see benefits, why not? Katie, would be okay. There's several in the webinar chat. I see questions that are relevant to hormones. Jacqueline Wiener says that she used Lupron Depot for about a year after she had been intractable migraine and exhausted all other migraine options, and that worked, which is not surprising, but that is a serious treatment. And so as a result, she's asking, have we seen women have success with an oophorectomy in situations like hers? Actually, there is data on oophorectomies, and the data is negative. So, and it's a study that really, I think, shows how burdened women are. That a subset of women who experience hormonally regulated migraine are so affected that they would be that debilitated to choose surgical option of oophorectomy to treat their headaches. To me, that breaks my heart that happens and that we still don't have often effective treatments for this subset of women. Unfortunately, that they would consider oophorectomy something so dramatic, and second, oophorectomies do not work. Actually, they will often exacerbate headache after short time of relief. In these small studies that have been conducted, the headache has been exacerbated over time. And the mechanistic reasoning for that is that when brain suddenly has a complete drop in estrogen and withdrawal from estrogen, as much as brain can be influenced by the fluctuations and present with all these symptoms, it really does not like the pain pathways, and brain overall does not like suddenly losing all of its estrogen supply. And therefore, actually, this is no longer advised, or the results were so dramatically negative that we are no longer advising or doing any other studies to follow up on that. There's another question that can you develop menstrual migraine at any age, or is it something you have your entire life? That for SP, they started in her late 20s and early 30s. Jessica mentioned earlier, it really depends. This is a multigenetic disorder that various things are expressed, meaning some genes are activated at various times during lifetime. And so we see we'll see twin sisters who have same genetics. One starts her migraine and menstrual migraine at age 15, and the other one starts at age 35. Why, how, we don't know. This is the challenge, and in a way, beauty of migraine, that there's a lot to study, but also challenging to understand all of it. But this story that SP shares is very common. And then I just wanted to hit
I'm going to jump in.
Yeah.
Oh, I just wanted to jump in and something kind of related to that. There's a
Yeah.
question in the Q&A. Can you have chronic migraine and menstrual migraine since you're getting migraine outside the menstrual window? Is it two different diagnoses?
It is two different diagnoses. We're both laughing because the trouble is when you have chronic migraine, sometimes it's really hard to piece anything else out. And what we will often see, and Ailani and I have talked about this so often that I know she agrees with me here, when you start to treat chronic migraine and the chronic migraine improves, what's often left behind is the menstrual migraine. So it tells you a lot about how difficult this disease can be to treat. And it does sometimes require its own kind of help where you're doing that mini bridge of a different type of medicine during that particular time, often layering a triptan and an NSAID, or my particular, I really like gepants around that time period because I don't think they cause a post-rebound effect of having a migraine the day after because you've had to use your triptan so many days. Along the same lines, there's lots of questions about not getting good migraine control, talking about being on a single agent. And I want to go back to this idea of layering treatment. And this goes for prevention as well. We're focusing on menstrual migraine, but many women with menstrual migraine have migraine with their menses and migraine other times of the month. And the goal really should be is overall reduction of frequency. And so you're left with the least number of attacks to have to work on. So that's going to require prevention, sometimes more than one preventive option. If you have something like chronic migraine, you might need 2 treatments to get your frequency down to 4 or less days a month. If we're aiming for going from 30 days a month to 10 days a month, that still is going to take probably more than one particular medicine. So that might be a conversation you really need to have with a specialist. I don't really know too many neurologists even that are going to really layer treatments in, and that would be a time to see a headache specialist for sure. And I think that is important to remember that if you're having a lot of attacks and having a hard time getting treatment, you might need more than one. You might need a huge toolbox and a toolkit. You might need a neuromodulation device. You might need to be using biofeedback, and you need to know when to pull all these tools around. So having a specialist for a headache is going to be really important there.
Agree. And just to add that depending on whom you ask in terms of getting the diagnosis, it is really essential that somebody with chronic migraine gets the chronic migraine diagnosis. Treatment of chronic migraine implies that it is a much broader treatment, automatically means this multi-pronged, multi-level, many kind of tools in the box will be needed. And therefore, it is essential that that diagnosis be met, and that is first and foremost. And then underneath that, depending on which one of our colleagues you ask, people would argue, can you have simultaneously both diagnoses or only one diagnosis? And Jessica elaborated on that, but that depends in terms of what is coded in the system and so on. At this point is what really matters in terms of having a diagnosis and being able to obtain the necessary medication through our healthcare system. It is really the chronic migraine diagnosis that needs recognition, and menstrually related migraine kind of falls under that and will be hopefully recognized and is really up. I think a patient who presents a compelling story. And also this is where the diary tracking really helps, and not just tracking the day, but tracking the features of the headache. So even if you were to have a headache every day, but if consistently the perimenstrual attacks are, every attack is 10 out of 10, and these are the days, a woman spends in bed and unable, and the typical acute medications are not helping, obviously the signal will show itself. So in those cases, I wouldn't focus even so much on diagnosis. As a patient, I think the advice is focus on chronic migraine and then focus on describing to the best of your ability to your clinician what other times are like, perimenstrual times are like. I see, Jessica, you're nodding your head.
There's a lot of questions also about specific treatments for menstrual migraine. I just think it's important we put out there at this very moment, there is no approved treatment for menstrual migraine, which is, I think, horrific, but is getting worked on, hopefully. Part of the reason for that is Certain triptans like frovatriptan and naratriptan, the longer triptans, were studied for menstrual migraine mini prevention. But both studies showed that at the end of the time period of taking it for 5 days, patients could sometimes develop an extra migraine attack, that rebound effect. So they never got FDA approved, but often those are the two that are used in clinical practice for that menstrual migraine attack, but they have to be scheduled. The other thing that's been studied has been naproxen. So it's the specific NSAID that's been looked at for menstrual migraine because it's a long-lasting NSAID. But that one has to be dosed an extremely long time. So the study showed 10 days of use of twice a day naproxen. And that's pretty difficult for most people, for their stomach to handle. To do this month after month, year after year for several years can be a bit difficult as well. So often, as Jelena was saying, we'll kind of time it a very short interval around when we know the patient is having attacks. Really, really great for a 20 and early 30-year-old. Not such an easy thing to do, as we're seeing patients in their 40s where that menstrual cycle starts to become very irregular. Maybe they have 3 cycles one month and no cycles the next month. And so then we're starting to converse about, can you get on hormone treatment to stabilize that? If not, let's start prevention. If one prevention isn't enough, let's do 2. And then let's think about a gepant around that interval of menstrual cycle. And again, this isn't based on what's been studied, but looking at the time period of life you're in, how predictable the attacks are, and what would be safe and not safe for your general health. These are the kinds of things that you're piecing together. And, Kate, you mentioned this, but it very much we're like hormonal doctors and headache specialists all in one, because it's such a big part of what we're doing. We might not be prescribing the hormone, but we're definitely consulting with the gynecologist on what would be okay, what to try next, what to think about, and what might be helpful. But it's not a
Yeah,
one.
I think it's really challenging for those of us living with migraine, because I feel like my headache specialist is not well versed in hormones. And when I talk to my PCP about hormone replacement therapy, she's like, "Well, I see you have migraine, so I think we should stay away from that." So it's like it's so hard to find that provider that understands the intersection. So that's why I'm so appreciative of you both being here tonight and sharing your
Thank you. But
knowledge
the
with us.
reality is, neurology training, and we are neurologists. Most headache specialists are neurologists. Neurology training does not include hormones. And at the time when most of us went to medical school, there were one lecture on menopausal transition and perimenopause. There has been very little training for the doctors that are currently working. This is changing right now, and there's more and more emphasis on this in the medical school curriculums, but not so much at the time when we went through the training. We recognize this by necessity, by the needs of our patients, and I think American Headache Society and other societies in this space, and Miles for Migraine, kudos to you for recognizing the need and having such sessions, because it's obviously highly relevant, as we can tell, to our patient population. There is a question about hormonal changes now that we're on hormones from Katrina Blank, and it's a very insightful question, asking that mid-cycle, that is ovulatory migraine, that the drop in estrogen that occurs during ovulation, at ovulation, in mid-cycle of the menstrual cycle. How is that? Is there migraine? Is that related to drop in estrogen? So yes, there's a drop in estrogen right at ovulation. That drop in estrogen is more robust than the drop in estrogen that I harped on, that occurs prior to menstruation. However, that particular drop in estrogen does not happen to be readily and statistically repeatedly involved with migraine attacks. Some women tend to be very susceptible at that time, and they will repeatedly and regularly and predictably experience these ovulatory headaches, but majority of women do not. And this is a very complex talk about hormones and neuroendocrine vulnerability that is beyond the scope of this. But most women do not experience predictable, repeated attacks at that time around ovulation, though there is a drop in estrogen.
I want to mention that someone's asking about, well, what do you do if you can't get prescription treatment right now and you're in the middle of it? I think this is a great question, very important. So this is the stuff I would tell my nurses when they didn't have a clinician and they'd ask me how to treat certain types of migraine. There's a bunch of things you can do. Success is very variable with these things, but they do sell. Some patients, ice is a real big helper. A fewer number of patients, heat is a big help. So they sell these amazing ice caps on Amazon. I highly recommend for anyone who's an ice person. You stick them in the freezer. They're super cold when they come out, but if you can tolerate it, you just put them on like a cap. And then that can be really helpful. Electrolyte fluids, not too much, no more than 16 ounces, or you'll get some diarrhea. So you don't want to do that to yourself. Acetaminophen, which is Tylenol, ibuprofen or naproxen, which are NSAIDs. These can be helpful, and you might need to take like an ibuprofen, some electrolyte water, the ice cap. You might like a menthol balm, like Vicks Vapor Rub, or camphor bombs, which are like Tiger Balm or Biofreeze, all very easily available over the counter. Even if you have prescriptions, these things can be very helpful during an attack to kind of add into your regimen. And then magnesium, you want to take about 500 milligrams. Magnesium glycinate or gluconate are going to be absorbed at the best. Otherwise, again, you'll end up with diarrhea. So nobody really wants that because you can already have GI issues when you're having a migraine attack. But one dose of that during an attack, especially during your menstrual time, so taking it once every night for 5 to 7 days can sometimes help suppress some of the abnormal signaling, and you can feel a little bit better. There have been studies that have shown that those that have menstrual migraine, their magnesium tends to dip during that time. So just supplementing it and bringing it back to baseline can be helpful. And then just taking it every day can be a helpful way to reduce migraine attacks without having to get a prescription. There are some neuromodulation devices you can get without prescription. The non-invasive vagal nerve stimulator that's sold as a Truvaga device, which you can just Google search and purchase on your own. And there's a Cephaly device that's a neurostimulator for the supraorbital nerves here, and that does not require prescription. So as time has gone on, I have watched a host of things become very available to our patients, and I have experienced patients trying these different things. The ice cap, I will tell you, is the number one, number two, number three recommended by most of our patients. And I think it can be very helpful, but all these other tools are out there for you as well.
I agree. I think what you said earlier, layering that one tool. I think oftentimes we expect I took my medication and I should be better. But listen to your body. You know, you've lived in your body your whole life. You know it better than any of us can after, spending 2-3 hours with you during the 6-month time, right? So we can guide you, but listen to yourself, follow your instincts, and help yourself in more ways than one if you feel you need them.
There is one other question here. How do you isolate potential interplay of PMDD for menstrual migraine?
Can be very hard.
Yeah, I will say that, the PMDD, that people will often describe pretty extreme emotional distress around that time, and it kind of will come on its own without migraine, or sometimes it's just mild headache and other symptoms. But if I will often tell my patients, if you have migraine and you're still having migraine, it's not part of PMDD. That is its own thing. That doesn't mean you can't also have PMDD that needs its own treatment. But treating one doesn't solve the other. You have to treat both. They're both important. And we do know that migraine can cause significant mood changes during the attack itself. But PMDD, I just always feel like the mood shift is so much more than what we see during a migraine attack. And the patients will describe some pretty extreme symptoms. That's when you're like, you really need to add that course of an antidepressant around that time to really get that better controlled.
But also women who have menstrually related migraine are more likely to have PMDD.
Mm-hmm.
All right, I'm just going to share my screen here as we get ready to close out. 2 things. We would love your feedback on our post-event survey. If you want to scan the QR code there, I can also drop it into the chat and we will send it out in an email tomorrow. But while things are fresh in your mind, it really helps us to know if this is the type of information that's helpful for you and what other topics you'd be interested in learning more about. I can't thank Dr. Pavlovich and Dr. Ailani enough for all the wealth of information you've shared with us tonight. It's amazing how much we can learn in just an hour. And an hour is also so much time. So thank you again. And I also have a QR code up here for donations if anyone's interested. Of course, the event is free tonight, but any donations go to help support us being able to continue to offer programs like this. So with that, we will close tonight out. The recording will be available to all of you. We'll get that sent out in the next couple of days, so you can feel free to watch it or share it with anyone else that may be interested. It'll be posted to our YouTube channel. And if you have any other questions or comments about tonight, don't hesitate to reach out to me. I'm Katie at milesformigraine.org, and we look forward to seeing you on our next webinar in a couple of months. Thank you, everyone.
Thank you. Good night. Good evening.
Thank you.